Hello everyone, welcome to Medicuisine. Today we are going to talk about management of seizures. Today's topic is management of seizures and different epileptic syndromes also. In the previous video we have talked in details about the seizures and epilepsy, the different types of seizures and the different epileptic syndromes actually. So the management of seizures is divided into two headings. Management of acutely seizing patient, which is actually the management of status epilepticus. What is status epilepticus? Status epilepticus is continuous seizure activity for more than 5 minutes. It may consist of a single seizure or multiple seizures with no or incomplete recovery of consciousness. And the second part will be regarding management of chronic epileptic patient, which is actually the management of epilepsy. So the first part will be regarding management of status epilepticus, and the second part will be regarding management of chronic epilepsy. Now let's talk about the management of acutely seizing patient, which is actually the management of status epilepticus. Not each and every person presenting with seizure needs to be treated. It is actually the status epilepticus which needs to be urgently treated. What is status epilepticus? As we discussed a few seconds ago, status epilepticus is having seizure activity continuously for at least 5 minutes. So only the patients having seizure activity for at least 5 minutes needs to be treated. Not every person having seizure activity needs to be treated. Remember this. Now let's have a look into first aid administration to patients who are having seizure. First aid goes for all patients. First aid is for all patients who are having seizure. First of all, move the person into a safe place, away from danger like fire, water, machinery. If the seizing patient is near fire, water or machinery or any other furniture, move the person into a safe place. After the convulsion ceases, turn the person into recovery position, which is the semi-prone position. And ensure the airway is clear and don't insert anything into the mouth of the person. As some people think that the tongue biting that occurs during seizure activity, they want to prevent that tongue biting actually, and then insert a piece of cloth into the mouth of the seizing patient. Don't do that. Remember, don't insert anything into the mouth of the person. If convulsions are not resolving spontaneously, if they occur for more than 5 minutes, seek urgent medical attention. Don't leave the person until fully recovered after the post-ictal symptoms. Observe the patient up to the post-ictal symptoms actually. Now, apart from the first aid administration, the medical intervention, the medical management is for those who are having status epilepticus only. Remember, as I said, first aid is for all patients who are seizing. First aid for all patients who are having seizure. And medical intervention is for those who have status epilepticus. How we actually manage status epilepticus? Through medicines. Before medicines, secure the airway, breathing and circulation. When the patient becomes hemodynamically stable, simultaneously evaluate and treat any precipitating cause. If you find any precipitating cause of the seizure, treat that precipitating cause. And if a reversible cause is identified, manage accordingly. Now, we are giving medicine to a patient who is having status epilepticus. The initial drugs of choice will be BZs, benzodiazepines, lorazepam or diazepam. So the benzodiazepines are the drugs of choice in status epilepticus. If you give lorazepam to a patient who is having status epilepticus and the patient continues to seize, add IV phenytoin or fosphenytoin. Remember, IV fosphenytoin is superior to IV phenytoin in several aspects. Like the onset of action of IV fosphenytoin is rapid as compared to IV phenytoin. The second aspect is IV phenytoin. When you use phenytoin IV, it carry the risk of purple glove syndrome, where there is purple blackish discoloration of the limb distal to the injection site. The IV fosphenytoin is safer in that aspect also. And with IV phenytoin, several side effects occurs like bradycardia and hypertension. Fosphenytoin is safer in that aspect also. After giving phenytoin or IV fosphenytoin, if the patient continues to seize, the seizure is not relieving, add phenobarbital. And if the patient continues to seize, the fourth option we are having is anesthesia. Anesthetize the patient with midazolam or propofol. Anesthetize the patient. So the first option we are having are benzodiazepines. The second, IV fosphenytoin. Third, phenobarbital. Fourth option, anesthesia. Anesthetize the patient with midazolam or propofol. Now, we said that the first option you are having when a patient suffers from status epilepticus is benzodiazepines, lorazepam or diazepam. The second option is IV fosphenytoin. The third option is phenobarbital. The fourth option is anesthesia with midazolam or propofol. Now there are three conditions where the management of status epilepticus slightly differs. Like when a patient develops status epilepticus while being in ICU, like when the status epilepticus is accompanied by severe systemic disturbances, like there is extreme hyperthermia, or the patient is seizing for like 60 minutes. If a patient is presented to you and the attendant says that this patient is seizing from the last 60 minutes, then the management of status epilepticus slightly changes. Like in these three scenarios, what will you do? You will proceed immediately to anesthesia after phenytoin or even lorazepam. You will proceed immediately to anesthesia after phenytoin or even lorazepam. You will give benzodiazepines like lorazepam. Then you will give fosphenytoin, and then you will give directly midazolam to anesthetize the patient. Or like this, you will give lorazepam, and directly after giving lorazepam, if the patient is still seizing, you will anesthetize the patient with midazolam. So these are the conditions in which the management of status epilepticus slightly differs from the usual management as we discussed few minutes ago. Now let's discuss when a patient has seizure for the very first time. How will you decide that is the patient needs anticonvulsant therapy or not? So in patients with first time seizure, when a patient experiences seizure for the very first time, how will you decide that is the patient needs anticonvulsant therapy or not? The patient will need anticonvulsant therapy if there is abnormal neurological exam. You examine the patient and there are abnormal neurological findings. If the patient is presented with status epilepticus, remember when a patient is presented to you with status epilepticus, after resolving the status epilepticus, you will put the patient on anticonvulsant therapy for quite some time. And if a patient has strong family history of seizures, and also if a patient has abnormal EEG, in these four cases, abnormal neurological exam, presentation with status epilepticus, strong family history, and abnormal EEG, the patient will need anticonvulsant therapy. The patient will need anticonvulsant therapy although the patient is experiencing seizure for the very first time. Now we are into the management of chronic epileptic patient. We have discussed the management of status epilepticus. Now we are into the management of chronic epileptic patient. Management of chronic epileptic patient. First of all, we will discuss about the management of absence seizures. You know, absence seizures occur as part of a syndrome, epileptic syndrome called childhood absence epilepsy, where there are multiple episodes of staring into the space, multiple episodes per day. So the absence seizures are treated with ethosuxamide. Ethosuxamide is the drug of choice for absence seizures. This is actually used as first-line therapy. Valproic acid is an acceptable option, but the drug of choice is ethosuxamide. The mechanism of ethosuxamide, it blocks the calcium channels, the postsynaptic type T calcium channels in the thalamus. And there may be GI side effects for the first few weeks, and along with GI side effects, insomnia, sleep disturbances, and hiccups may also occur. What is the mechanism of action of valproic acid? It blocks sodium channels and potentiates GABA, the inhibitory neurotransmitter in the brain. It also acts as mood stabilizer. So anticonvulsant with mood stabilizing ability, valproic acid. There is also one other anticonvulsant which also acts as mood stabilizer. We will discuss that also. So the famous side effect of valproic acid is weight gain. Now let's discuss the treatment of generalized tonic-clonic seizures. Remember, in case of generalized tonic-clonic seizures, no single drug is considered superior. All are equally effective, like valproic acid, phenytoin, lamotrigine, carbamazepine, and levetiracetam. All are equally effective. By the way, what is the mechanism of action of phenytoin? It blocks sodium channels. It is a narrow therapeutic index, so constant blood level monitoring is required when you put a patient on phenytoin. The side effects of phenytoin include gingival hyperplasia and body hair growth. What is fetal Hydantoin syndrome? Fetal Hydantoin syndrome is associated with phenytoin use in pregnancy. When you put a pregnant woman who is having epilepsy on phenytoin, the fetal Hydantoin syndrome may occur. What happens in this syndrome? It causes growth deficiency in the fetus. It also causes abnormal facial features like broad nose, wide-spaced eyes, malformed ears, and microcephaly. And it causes birth defects like cleft lip, cleft palate. So fetal Hydantoin syndrome is associated with growth deficiency, intrauterine growth deficiency, abnormal facial features, and birth defects like cleft palate, cleft lip. And it is associated with phenytoin use in pregnancy. What are the symptoms of acute toxicity of phenytoin? Overdose of phenytoin. It includes altered mental status, nystagmus, ataxia, abnormal reflexes. By the way, phenytoin versus fosphenytoin. Which one is superior? We discussed this comparison earlier in this video. IV phenytoin is associated with purple glove syndrome, and fosphenytoin is safer in that aspect. Rapid onset of action. Phenytoin has late onset of action. Fosphenytoin has rapid onset of action. So it is considered superior in case of treating a patient with. What is the mechanism of action of carbamazepine? It is a sodium channel blocker. Side effect includes SIDH, syndrome of inappropriate ADH secretion. And it can also cause Stevens-Johnson syndrome, very classical for carbamazepine. Don't forget Stevens-Johnson syndrome association with carbamazepine. Mechanism of action of lamotrigine, sodium channel blocker. It also inhibits presynaptic glutamate and aspartate release, and it also acts as a mood stabilizer. So what was the first anticonvulsant we studied today which also acted as a mood stabilizer? It was valproic acid. Topiramate. What is the mechanism of action of topiramate? It blocks sodium channel and potentiates GABA. And regarding side effects, it causes sedation, mental tulling. Topiramate is also a weak carbonic anhydrase inhibitor, can cause mild metabolic acidosis, and it carries the risk of urinary stones because it reduces the urinary excretion of citrate. When the urinary secretion of citrate is decreased, there is free calcium in the urine which can precipitate and cause urinary stones. Now let's talk about the treatment of myoclonic and atonic seizures. By the way, what was the epileptic syndrome that was associated with myoclonic seizures? It was juvenile myoclonic epilepsy. Don't forget the children who are getting up from sleep and had myoclonic jerks, the jerking body movements. And what was epileptic syndrome that was associated with atonic seizures? Tonic and atonic seizures. The Lennox-Gastaut syndrome. Lennox-Gastaut syndrome. So for myoclonic and atonic seizures, we will go for valproic acid, which is regarded the treatment of choice. Now, how we actually treat focal seizures? Do you remember what were the syndromes associated with focal seizures? The temporal lobe epilepsy, the benign Rolandic epilepsy. These were the two syndromes we have studied in the previous lecture which were associated with focal seizures. Remember, all the focal seizures are treated the same, whether they are simple, whether they are complex. They are treated the same. Carbamazepine, phenytoin, they are considered first-line therapy, and valproic acid, lamotrigine are acceptable alternatives to these carbamazepine and phenytoin. Phenytoin, carbamazepine. Now a question is here which asks when to stop therapy. This is very difficult to answer. But if a patient has been free of seizures for 2 to 3 years, you can stop the therapy. If you want to assess the patient for the risk of recurrence, if a patient is not having any seizure from the last 2 to 3 years and you want to stop the therapy, you will assess the patient for risk of recurrence. You can actually assess the patient. How will you assess the patient? Sleep deprivation EEG. If the sleep deprivation EEG comes out to be normal, it means the child has very low risk of recurrence and you can actually confidently stop the therapy. Remember, be very careful to treat epilepsy in pregnancy. Most of these anticonvulsants are folate antagonists and causes birth defects like cleft lip, cleft palate and many more. There is no drug superior which is considered superior in pregnancy. However, they say that lamotrigine and levetiracetam are relatively safe to be used in pregnancy. Remember, and valproic acid, phenytoin, they are very dangerous to be used in pregnancy. Valproic acid and phenytoin, they are very dangerous to be used in pregnancy. Lamotrigine, levetiracetam are relatively safe. They say like this. So this was something about the treatment and management of seizures and different epileptic disorders. Hope you understand well. If you have any question, please comment down.